Welcome to the Deep Dive, your shortcut to mastering complex material. Today, we are really diving deep into the hand and wrist. You could argue it's the most crucial region for human existence.
That's right.
We're using some top-tier surgical texts here, aiming to build a really solid professional understanding of the anatomy, the specific problems, the pathologies, and the principles behind treating this unique area.
And it's a deep dive where, precision is just everything. The hand, it's not just complicated. It's a system with incredible integration. Our sources really define the core mission of hand surgery, not just as, fixing things, but as a deliberate push to maximize 4 key goals.
Okay.
Mobility, sensibility, stability, and strength, and all while minimizing pain and, crucially, tailoring it all to the patient's specific issue.
And when you think about its uses, the hand goes way beyond just activities of daily living, right?
Oh, absolutely.
It's central to work, to recreation, communication itself. Our source material really highlights this, noting how it lets the blind read Braille, the mute speak through sign language. It's sensory, motor, communication, all in one package.
Exactly. And that kind of multifaceted nature is precisely why hand surgery developed as its own regional specialty.
Yeah.
It absolutely demands integrating 4 major surgical fields: neurologic, orthopedic, plastic, and vascular surgery.
So you can't just look at a hand injury as, say, just a broken bone or cut tendon.
No, you missed the whole picture. The success of anything you do hinges on weaving together all 4 perspectives.
Okay, so let's be really clear about our mission for this deep dive. We need to master the foundational anatomy because, as our sources really hammer home, true mastery of diagnosis and successful treatment in this incredibly integrated region flows directly, almost exclusively, from really understanding those underlying structures. All right, let's get into it. #tag2, foundational anatomy and directional terminology. We have to start with the specific language, the terminology for the hand, because the usual anatomical terms, they just don't quite cut it here.
They really don't. Straight away, we have to clarify position and motion. Because the hand rotates, pronation, palm down, supination, palm up, we just can't reliably use terms like medial and lateral.
Right. They change depending on rotation.
Exactly. So instead, we use radial towards the radius or thumb side, and ulnar towards the ulna or small finger side. Those are fixed. They don't change with rotation. Then you have palmar, or sometimes called volar, for the anterior or grasping surface.
Okay.
And dorsal for the posterior surface, the back of the hand.
And the movement of the fingers, the digits, that's specialized too.
Highly. For finger movement, abduction means spreading them away from the middle finger.
Okay, middle finger is the reference point.
Yes, and adduction is bringing them toward the middle finger. The middle finger itself is that central axis. Moving on to the bony structure, the architecture. It's really a masterpiece of precision. 19 bones organized into 5 rays. We number them 1 to 5, starting with the thumb, but conventionally we just use their names: thumb, index, middle ring, and small fingers.
Let's talk about the main joints, the metacarpophalangeal joints, the MP joints.
Right, the knuckles. They typically give you a maximum of about 90 degrees of flexion, which is key for a strong grip. There's usually a little bit of hyperextension possible too. Functionally, this is where the fingers actively abduct and adduct, spread, and close. The thumb, though, its MP joint, mainly moves in a simpler flexion-extension plane.
And then the interphalangeal joints, the IT joint.
Those are really the core of finger mobility. The proximal interphalangeal, or PIP joint, the middle knuckle, is critical. It moves from 0 degrees, fully straight, to about 95 degrees of flexion.
And the distal one.
The distal interphalangeal, or DIP joint, moves from 0 to about 90 degrees. The thumb just has 1 IP joint, and it averages about 0 to 80 degrees.
Now, you mentioned a foundational rule about the ligaments supporting these joints. I want to spend a second on this because getting this wrong, the consequence is, irreversible stiffness.
This might be the most important anatomical detail for anyone managing hand trauma. Both MP and IP joints are supported by radial and ulnar collateral ligaments. The absolutely crucial rule for splinting, for immobilization, is this: IP collateral ligaments are tight, they're on tension, only when the joint is fully extended at 0 degrees.
Okay, straight finger, tight IP ligaments.
Exactly. Conversely, MP collateral ligaments are tight, on tension, only when the joint is fully flexed at about 90 degrees, like making a fist.
So if you immobilize the hand in any other position for too long,
those ligaments will shorten, they contract, and you end up with stiffness.
So splinting someone with their knuckles, the MPs straight, and their fingers bent, which is often the position of comfort.
That's a disaster waiting to happen. Those ligaments shorten, and the patient loses the ability to make a full fist or straighten their fingers completely later on.
And that stiffness is often permanent.
Often irreversible, yes. Then the patient needs more surgery mobilization procedures like capsulotomies or tenolysis, and honestly, those rarely, if ever, get back normal range of motion. That's why the intrinsic plus position, we'll talk more about MPs flexed, IPs straight, it's not just a suggestion, it's really a mandated splinting position. It protects function and prevents this really devastating secondary problem.
That really hammers home how critical knowing the anatomy is for actual clinical practice. Okay, moving proximally, let's tackle the wrist. 8 carpal bones, 2 rows. It's complex.
It is. The proximal row has the scaphoid, the lunate, and the triquetrum. The lunate is often seen as the main axis for motion. It connects with the radius, and it takes about 35% of the axial load, the force going through the wrist.
The scaphoid is interesting, its shape and its role as a bridge.
Yes, the scaphoid is sort of keel-shaped. It's the key link between the proximal and distal carpal rows. Structurally, it bears the most load, around 55%.
So scaphoid 55%, lunate 35%. Where's the rest?
The last 10% goes through the triangular fibrocartilage complex, or TFCC. That structure interacts with the triquetrum and the distal ulna. Understanding that 553-528 load split is really key to understanding wrist mechanics and how injuries happen.
Okay, distal row, trapezium, trapezoid, capitate, and hummet.
The trapezium is highly specialized. It's got this saddle-shaped surface where it meets the thumb metacarpal. That specific joint, the carpometacarpal or CMC joint of the thumb, that's what gives us that incredible mobility and opposition that defines the human hand's dexterity. The capitate is the biggest carpal bone, and it's the first one to start forming bone, ossify, so it's structurally important.
And the stability across that distal row varies quite a bit.
It really does. The CMC joints for the index and middle fingers are very stable, almost no movement. But the ring and small finger CMC joints are quite mobile, mostly in flexion extension. That movement is important for cupping the hand and for power grip.
And then there's the pisiform. Our sources called it a geographical carpal bone.
Functionally, it's different. It's really a sesamoid bone, like the kneecap, embedded right in the flexor carpi ulnaris, or FCU, tendon. It doesn't bear any load. Its main job is to slightly improve the leverage of the FCU muscle. Clinically, you can actually remove it, excise it, without any real functional loss.
All right, we have the bony framework. Now let's look at the engines, the motors. The extrinsic muscles starting up in the forearm that drive the bigger hand and wrist movements.
Yeah, the wrist movers are pretty clear functional groups. For flexion, you've got the flexor carpi radialis, FCR, the flexor carpi ulnaris, FCU, and the palmaris longus, PL.
FCR, that's median nerve.
Correct. XCR is median nerve, and it pulls the wrist toward the thumb side, radial deviation. The FCU is critically different. It's innervated by the ulnar nerve, and it pulls the wrist towards the small finger side, ulnar deviation.
And the palmaris longus.
Also median nerve. It's unique because it inserts into the palmar fascia, the connective tissue in the palm, not bone. And interestingly, it's just absent in maybe 15% of people.
Okay, now the extensors on the back of the wrist.
All 3 main wrist extensors get their nerve supply from the radial nerve or its branches. You have the extensor carpi radialis longus, ECRL, the extensor carpi radialis brevis, ECRB, and the extensor carpi ulnaris, ECU. The ECRL and ECRB primarily extend the wrist and insert near the base of the middle finger metacarpal. The ECU helps with extension and also with ulnar deviation.
Moving deeper, the long digital flexors, the ones that bend the fingers.
Right, layers of function here. The flexor digitorum superficialis, FDS, attaches to the middle phalanx, so it bends the PIP joint, the middle knuckle. The flexor digitorum profundus, FDP, goes all the way to the distal phalanx, the fingertip bone, so bends the DIP joint. And the flexor pollicis longus, FPL, does the same for the thumb's IP joint.
This is where that complex nerve mapping really starts to matter for diagnosis. 3 different nerves controlling movement, median, ulnar, radial. It seems almost, well, deliberately complicated. Specifically, the long flexors have that split innervation we need to grasp.
That split is absolutely fundamental for diagnosing high median or high ulnar nerve injuries. So while the FTS muscle and the FT key tendons going to the index and middle fingers are supplied by the median nerve,
Okay.
the FTP tendons going to the ring and small fingers are innervated by the ulnar nerve. So if you damage the ulnar nerve high up, say the elbow, you'll lose the ability to bend the tips of the ring and small fingers. But the index and middle might still bend normally. That's a key diagnostic sign.
Makes sense. What about the extrinsic digital extensors, the ones straightening the fingers?
All of those are innervated by the posterior interosseous nerve, or PI, which is a branch of the radial nerve. The main one is the extensor digitorum communis, EDC. It straightens the MP joints, the main knuckles. But here's another structural quirk. The EDC doesn't attach directly to bone at the MP joint. It inserts into this soft tissue sling called the sagittal hood, which wraps around the base of the proximal phalanx.
So the EDC straightens the MP joint using that hood, but straightening the IP joints, the middle and end joints, relies more on the intrinsic muscles.
Precisely. The intrinsics are the real engines of fine, detailed movement. Let's break those down. We group them into the thenar muscles on the thumb side, the hypothenar muscles on the small finger side, the lumbricals, and the interossae.
The thenar group abductor pollicis brevis, APB, opponens pollicis, OP, and the superficial head of flexor pollicis brevis, FPB, that's median nerve, right? And responsible for opposition, pinching the thumb to the fingers.
Correct. That opposition is a defining human movement. Then the lumbricals. These are fascinating anatomically. They don't start from bone. Uniquely, they arise from the FDP tendons down in the palm.
Wow, okay.
And their action is really elegant.
Yeah.
They flex the MP joints, the main knuckles, while simultaneously extending the IP joints, the finger joints. It's the perfect motion for things like writing or holding a small object precisely.
And their innervation.
It splits exactly like the FDP tendons they come from. The lumbricals for the index and middle fingers get median nerve supply. The lumbricals to the ring and small fingers get ulnar nerve supply.
So that triple nerve split, radial for extensors, medial nerve for the long flexors, and medial nerve again for the intrinsics like lumbricals is just essential mapping for figuring out nerve injuries.
It absolutely is. Then we have the hypothenar group abductor digiti quinti, ADQ, opponens digiti quinti, ODQ, and flexor digiti quinti, FDQ. They are all ulnar nerve innervated, and they provide sort of the reciprocal motion to the thumb's opposition, cupping the small finger side. And finally, the interosseous muscles. Palmar ones duct, bring fingers together, dorsal ones abduct, spread fingers apart. They also help flex the MPs and extend the IPs. And importantly, they're all innervated by the ulnar nerve. That includes the deep head of the FPB and the adductor pollicis muscle in the thumb as well.
So connecting this back, a pure ulnar nerve injury, say at the wrist level, would knock out almost all of those intrinsic muscles, leading to major problems with fine motor control.
Absolutely. Severe impairment. That motor geography is the roadmap for diagnosis.
Yeah.
But these tendons, they need structural support to work efficiently. Which brings us to the pulley systems.
The retinacula and pulleys. Their job is simple but vital, right? Keep the tendon snug against the bone.
Exactly. It ensures that when the muscle pulls, maximum tendon movement translates into maximum joint bending instead of the tendon lifting off the bone like a bowstring.
And the most famous one is the flexor retinaculum, the transverse carpal ligament. That's the roof of the carpal tunnel.
Correct. And inside that very tight space, we find precisely 10 structures. 4 FDS tendons, 4 FDP tendons, the 1 FPL tendon for the thumb, and critically, the median nerve. 10 structures packed in there.
On the back, the dorsal side, there's the extensor retinaculum divided into 6 compartments. You mentioned this list is important because certain types of tendinitis, tenosynovitis, are named after the compartment.
That's right. Compartment 1, right over the radial styloid bone, holds the abductor pollicis longus, APL, and extensor pollicis brevis, EPB. This is the spot for de Quervain's tenosynovitis, a very common condition. Compartment 2 has the 2 radial wrist extensors, ECRL and ECRB. Compartment 3 holds the extensor pollicis longus, EPL, the long thumb extensor, which actually hooks around a little bony bump called Lister's tubercle. Compartment 4 contains the EIP, extensor indicis proprius for the index finger, and the EDC tendons, the common finger extensors. Compartment 5 is just the EDQ, extensor digiti quinti, for the small finger. And compartment 6, the most ulnar one, holds the ECU, extensor carpi ulnaris.
And deep inside the fingers themselves, we have the digital pulleys. Annular ones, A1 to A5, and cruciate ones, C1 to C3. Our sources highlighted A2 and A4 as being critical.
Yes, A2 and A4 are the biomechanically crucial pulleys. They are the strongest and do the most work preventing the flexor tendons from bowstringing away from the bone, especially during strong gripping. Ruptures here are common in rock climbers. All right, let's shift to the blood supply and nerves. 2 main arteries feed the hand, the radial artery and the ulnar artery.
The radial artery. It splits.
It does, near the wrist. A smaller superficial branch goes to help form the superficial palmar arch. But the larger branch actually dives dorsally, passes through that anatomical snuff box on the back of the thumb base, and then comes back volarly into the palm to form the main part of the deep palmar arch.
And the ulnar artery.
It travels down the forearm, deep to the FCU muscle, enters the palm through Guillen's canal next to the pisiform bone, and its larger branch forms the main contribution to the superficial palmar arch.
The interesting thing here you mentioned is the redundancy.
It's a huge surgical safety net. In about 97% of people, either the deep or the superficial palmar arch, or both, is complete, meaning there's a connection between the radial and ulnar systems.
So the hand can usually survive on flow from just one artery if the other is damaged or needs to be tied off.
Typically, yes. It allows surgeons to ligate or tie off one of the main vessels if necessary during surgery, though obviously repairing it is always the ideal goal if possible.
Zooming into the fingers, each one gets a radial and an ulnar digital artery. Where do they run relative to the nerves? This is important for surgery.
Very important. They travel along the sides of the bones and tendons, generally just palmar, or towards the palm side of the midline of the digit. But crucially, they run dorsal to the proper digital nerves.
So the nerves are more superficial, more palmar than the arteries.
Generally, yes. When dissecting from the palmar side, you typically encounter the nerve just before the artery. Vital to remember that relationship.
Okay, let's map out the three major nerves territories, starting with the median nerve, which you said is the most critical for sensation.
It really is for functional sensation. It covers the volar or palmar, surface of the thumb, index, middle, and the radial half of the ring finger. Important branches to know. The palmar cutaneous branch, PCN, comes off about 6 centimeters before the wrist crease in the forearm. It supplies sensation to the skin over the base of the thumb, the thenar eminence.
And because it branches off early, it's usually spared in carpal tunnel syndrome surgery.
Exactly. The numbness from CTS doesn't typically involve that patch of skin. The motor branch to the thenar muscles, the thumb muscles, most commonly takes a recurrent path, meaning it branches off inside the carpal tunnel and curves back up to supply the muscles. And higher up in the forearm, the anterior interosseous nerve, AIN branch, carries motor fibers to some deep forearm muscles, including the FPL and FDP to index middle fingers.
Okay, the ulnar nerve. It handles the rest.
Pretty much. Motor-wise, it supplies the FCU muscle and the FDP tendons to the ring and small fingers up in the forearm. Then, about 5 centimeters above the wrist, it gives off the dorsal sensory branch, which provides sensation to the back, the dorsal side, of the ulnar hand and small ring fingers. In the hand itself, the deep motor branch of the ulnar nerve innervates all those intrinsic muscles we talked about, the hypothenars, all the introsi, the ulnar two lumbricals, the adductor pollicis, pretty much everything except that median innervated group.
And the radial nerve, mostly extensors and dorsal sensation.
That's right. The radial nerve itself, higher up, supplies the ECRL. Then its deep branch, the posterior interosseous nerve, PIN, takes over and innervates all the other extensors in the forearm and wrist. Sensation is provided by the superficial radial nerve, SRN. It covers the dorsal side of the radial part of the hand, the thumb, index, middle, and half the ring finger, but only up to about the middle knuckle, the PIP joint level. The very tips of the fingers dorsally get their sensation from branches of the median and ulnar nerves that wrap around. #mitosi, hand examination and imaging modalities.
Okay, that deep anatomical knowledge really sets the stage. Now let's apply it to that first clinical encounter. The acute examination of an injured hand.
Right. Inspection, just looking, has to start by noting the normal resting posture, or cascade. The fingers should naturally fall into slight flexion, with the small finger usually bent the most and the index finger the least. If that cascade is disrupted, if one finger is sticking straight out or overly bent.
That immediately suggests a problem, like a cut tendon or maybe a rotational fracture.
Exactly. Then, perfusion assessment. Checking blood flow is critical in acute injuries. Beyond just feeling for the radial and ulnar pulses, we often use a pencil Doppler. But if there's any real doubt about tissue survival, the crucial test is a simple 25-gauge needle prick to the pulp, the fleshy part of the fingertip. Bright red capillary bleeding confirms that blood is getting there. If it's dark, sluggish, or absent, that's an emergency. We're fighting against warm ischemia time.
In this next point, you stress it's non-negotiable in an acute situation.
Absolutely non-negotiable. Sensation must be tested and documented thoroughly before you give any local anesthetic. This is just critical, legally and medically.
What's the minimum check?
Minimum is testing light touch and sharp touch, like with a bent paperclip, on the radial and ulnar tips of each injured digit. For a more detailed exam, the gold standards are 2-point discrimination or using Semmes-Weinstein monofilaments. The rule is, any sensory loss after a sharp injury, like a cut, must be assumed to be a nerve laceration until you can prove otherwise.
Okay, moving to function testing. You mentioned isolating the flexor digitorum superficialis, the FDS, is a classic maneuver. Why do we need to hold the other finger straight in hyperextension when testing, say, the middle finger's FDS?
That's a great question that goes right back to the anatomy we discussed. We hold the other three fingers straight to stop the flexor digitorum profundus, FDP, from working.
Because the FDP tendons share a muscle belly.
Exactly. The FDP tendons to fingers 2 through 5 originate from a common muscle belly up in the forearm. So if you try to bend one fingertip, DIP joint, the others tend to want to bend too because they're linked. The FDS, however, has mostly separate muscle bellies for each tendon. So by holding the other fingers straight, you prevent the common FDP from activating, allowing you to isolate and test the strength of just the FDS tendon to the finger you're interested in, checking its PIP joint flexion.
Clever. Okay, finally, in the acute exam, looking for infection, redness, swelling, fluctuance, that boggy feeling, localized tenderness.
Yes, and remember that structural difference. The back of the hand, the dorsum, doesn't have strong fascial compartments like the palm. So dorsal infections can spread really widely and quickly, often presenting with dramatic swelling.
And always check upstream.
Always palpate the regional lymph nodes, the epitrochlear node just above the elbow on the inside, and the axillary nodes in the armpit. Swollen, tender nodes suggest the infection is spreading.
All right, let's look at imaging, starting with the workhorse. Plain x-rays. AP, lateral, oblique views. We're looking for obvious fractures, of course, but also subtle things.
Subtle things like lucencies, darker areas in the bone, which might suggest a tumor or an infection. And at the wrist, checking Jalula's arcs is critical.
Remind us about those arcs.
You mentally draw 3 smooth curves on the AP view. One along the proximal articular surfaces of the proximal row, staphoid, lunate, trigetrum. One along their distal surfaces, and a third along the proximal surfaces of the distal row, capitate, hamate. If any of those arcs are broken, if there's a step off, it strongly implies a ligament injury or a dislocation between the carpal bones, and that needs more investigation, usually a CT or MRI.
And checking joint congruency.
Yes, especially in the fingers. If a joint looks like it's not sitting quite right, even subtly, it often means there's an associated fracture with some rotation, and rotational deformities usually need surgery to fix properly.
For better bone detail, especially in really complex fractures like a shattered distal radius or trying to see exactly how displaced a scaphoid fracture is, computed tomography, CT, is the way to go.
Absolutely. And our sources actually confirm something clinically useful. For those suspected scaphoid fractures that look normal on the initial X-ray, getting a CT scan early might actually reduce overall morbidity and cost by avoiding weeks of unnecessary casting if the CT is negative, or confirming the fracture sooner if it's positive. CT isn't as helpful, though, for looking for abscesses in the hand's soft tissues.
For soft tissues, ligaments, tendons, swelling magnetic resonance imaging, MRI is the gold standard.
MRI gives beautiful, non-invasive pictures of ligament tears, like in the wrist, or tendon inflammation, tendonitis, or just general edema and swelling. It's also key for picking up occult hidden abscesses, especially if you use contrast dye. It can show hidden fractures by highlighting the bone bruise or edema.
And specifically for the scaphoid.
MRI is crucial for diagnosing a vascular necrosis, AVN, where the bone loses its blood supply after a fracture. The lack of signal on certain MRI sequences, particularly T1-weighted images, is the definitive sign of AVN.
Ultrasonography seems operator-dependent, but it has that advantage of being dynamic.
Highly operator-dependent, yes. But it's great for looking at soft tissue structures right at the bedside. And yes, the dynamic aspect is key. You can watch tendons glide as the patient moves their fingers, or use it to track down elusive foreign bodies like wood splinters.
And traditional angiography, injecting dye directly into arteries.
It's rarely needed now because CT angiography and MR angiography give such good images non-invasively. It's really reserved for specific situations like severe blood clots, thrombotic processes, where you might need to go in via the femoral artery in the leg to deliver clot-busting drugs directly to the hand arteries.
Let's apply this to specific trauma patterns. When we describe a fracture, precise language is key. Displacement.
Displacement is described as a percentage of the bone's diameter that the fragments are offset. Rotation is in degrees, supination, or pronation. And angulation is also in degrees, describing which way the apex of the angle points, like volar or dorsal.
And after the initial impact, the muscles start pulling on the pieces.
Right, the deforming forces are mainly the tendons pulling the fragments, usually proximally up the arm and volarly towards the palm. The fracture pattern often tells you about stability. Transverse fractures, straight across, are relatively stable. Oblique fractures, angled, tend to slide and shorten. Spiral fractures are inherently unstable because they shorten and rotate, and they almost always need surgery.
Common injuries. Tuft fractures, just the very tip of the finger bone.
Usually just need protection, like a simple splint. Displaced phalangeal shaft fractures often need reduction, usually pulling traction to realign them. But fractures that go into the joint surface, articular fractures, are a major worry.
Why? Risk of stiffness.
Exactly. They disrupt the smooth joint surface, leading to arthritis and stiffness. So they often need very precise surgical fixation, followed by carefully controlled early motion therapy to prevent the joint from freezing up.
A classic injury is the PIP joint dislocation, the middle knuckle popping out, usually dorsally.
Right. The reduction maneuver is usually straightforward. Gentle pressure on the base of the dislocated phalanx to guide it back over the head of the proximal phalanx, followed by gentle flexion. Then you splint it in slight flexion. The exception, the time when you can't reduce it closed, is when the head of the proximal phalanx actually gets buttonholed, trapped between the two slips of the FDS tendon. That needs open surgery to release it.
Metacarpal fractures, like the boxer's fracture, the neck of the small finger metacarpal, often stable.
Often stable, especially after the JAWS maneuver. That involves fully flexing the patient's finger at the MP joint, using the tight collateral ligaments and the flexed finger itself to push the fracture fragment back into place with thumb pressure on the apex from the back.
Contrast that with thumb-based fractures, Bennett and Rolando fractures. Highly unstable.
Very unstable. The strong pull of the thumb muscles, particularly the abductor pollicis longus, just pulls the main metacarpal fragment off the small base fragment that's still attached to the trapezium. These almost always need surgical fixation, ORIF, open reduction, and internal fixation.
And the scaphoid. It's always the exception, isn't it? Even if it looks non-displaced, that precarious blood supply means it can fail to heal non-union in up to 20% of cases.
It's the troublemaker. That's why even just suspicion of a scaphoid fracture means immediate thumb spica splinting and a definite follow-up appointment in about 2 weeks, potentially with repeat x-rays or advanced imaging.
Does surgery help the healing rate?
Interestingly, surgical fixation might shorten the time to union by maybe 6 weeks compared to casting, which is good for getting people back to activity sooner, but it doesn't necessarily increase the overall chance of it eventually healing, assuming it was truly non-displaced to begin with. The main benefit of early surgery for suspected scaphoid fractures is avoiding missing a non-union that could have devastating long-term consequences for the wrist.
And for severe wrist ligament injuries, like a complete staphylinate tear, the Mayfield classification describes the stages of instability, with the worst being the lunate bone completely dislocating into the carpal tunnel. That's an emergency.
Absolute emergency. It causes acute, severe median nerve compression and needs urgent surgical reduction and stabilization.
Okay, so after any significant trauma, protecting the hand is key. This brings us back again to that critical splinting position.
The intrinsic plus position.
Yes.
Cannot emphasize it enough. MP joints flex to about 90 degrees, IP joints fully extended at 0 degrees, and the wrist held in slight extension, maybe 15-20 degrees. This keeps those vital collateral ligaments on stretch, preventing that secondary stiffness we talked about.
Moving to soft tissue injuries. Tendon cuts, how do you suspect them?
Loss of that normal resting cascade is a big clue. Or you can use a tenodesis maneuver, passively flexing and extending the patient's wrist. With an intact system, wrist extension should cause the fingers to passively flex, and wrist flexion should cause them to extend. If a finger doesn't follow along, its tendon might be cut.
Flexor tendon injuries are classified by zones. Zone 2, that area in the finger between the distal palm crease and the middle knuckle, that was no man's land.
Historically, yes. From roughly the A1 pulley to the FDS insertion. Primary repair in this zone used to have terrible results, lots of scarring and stiffness, so surgeons often avoided it. But pioneering work, especially by Dr. Kleinert, established that meticulous primary repair combined with very specific early controlled motion therapy protocols could give good results.
So the repair itself is done in the operating room?
Yes, ideally. In the emergency department, you'd wash out the wound thoroughly, maybe loosely close the skin, splint it appropriately, and get the patient to a hand surgeon for definitive repair in the OR.
And the splinting after a flexor tendon repair?
The wrist is usually splitted in slight flexion, maybe 20 degrees, and the MP joint's also flexed. This takes tension off the repair site, reducing the force from the muscle pulling proximally.
Extensor tendons on the back of the hand, they don't have that tight pulley system like the flexors?
No tight sheath in the fingers, correct. So, repair bulkiness is less of an issue. Distal injuries, right at the fingertip, like a closed mallet finger where you can't straighten the tip. That's usually treated non-surgically with 6 straight weeks of continuous extension splinting of the DIP joint. No cheating. If it's an open cut over the DIP joint, you might use a dermatotenodesis suture technique. For more proximal extensor tendon cuts over the finger or hand, repairs are often done with figure of 8 or horizontal mattress sutures, typically using a 3-0 braided permanent stitch.
And the splinting for those proximal extensor repairs is interesting. It's a compromise.
It is a deliberate compromise. The IP joints, the finger joints, are splinted straight in extension, but the MP joints, the main knuckles, are splinted in about 45 degrees of flexion.
Why flex the MPs if the IPs are straight?
That 45 degrees of MP flexion actually relaxes the tension on the extensor tendon or repair site further up on the hand or finger. It's necessary to protect the repair. But, as you pointed out, anatomically, that's suboptimal for the MP collateral ligaments, which prefer 90 degrees of flexion to stay stretched. So the surgeon is making a calculated decision, prioritizing the healing of the tendon repair in that specific situation.
For nerve injuries, the rule holds. Sensory loss after a sharp cut means a nerve laceration until proven otherwise.
Absolutely. These need microsurgical repair. While sometimes exploration can be delayed a bit, earlier repair within the first week or two is generally preferred to minimize scar formation between the nerve ends. The key is that the surgeon needs to trim the nerve ends back to healthy-looking fascicles before sewing them together under the microscope.
Vascular injuries potentially limb or digit threatening. First step is controlled bleeding.
Direct, firm, local pressure, held continuously for at least 10 minutes. That often works. If not, an upper extremity tourniquet can be applied, inflated to about 100 millimeters of mercury above the patient's systolic blood pressure. But you have to watch the class Terry. The generally accepted safe limit for tourniquet time is less than 2 hours to avoid muscle damage or nerve injury from lack of blood flow.
Ligate or repair, given that 97% redundancy.
Ligation, tying off a bleeding vessel, is often safe for digit survival, especially if it's just one of the two digital arteries. However, particularly in academic centers, repair is often encouraged whenever feasible, partly to give residents crucial experience for managing those situations where repair is absolutely necessary to save a digit or the hand.
Let's talk local anesthesia, specifically the old fear about using epinephrine in the hand or fingers. That's largely dispelled now.
Largely, yes. The historical dogma was that epinephrine's vasoconstriction could cause finger necrosis, tissue death, but multiple large studies have shown that it's generally safe when used correctly. The exceptions are maybe the very distal fingertip, and you absolutely must use the correct concentration, no stronger than 1,100,000 epinephrine.
And the benefits are?
A much drier surgical field because of the vasoconstriction, and it significantly prolongs the effect of the anesthetic, meaning less is needed overall.
And to make the injection itself less painful?
Adding a small amount of sodium bicarbonate solution to the anesthetic vial just before injection helps a lot. It buffers the typically acidic lidocaine or bupivacaine solution, making it closer to the body's pH and reducing that initial stinging sensation.
For duration, mixing anesthetics is common.
Very common. Often mix lidocaine, which has a rapid onset, with bupivacaine, which lasts much longer, maybe 6 to 8 hours, giving prolonged post-procedure pain relief.
This all leads into the concept of wide-awake local anesthesia, no tourniquet or wallant.
Wallant has been a huge advance in hand surgery. It uses local anesthesia, often with epinephrine for hemostasis, but without any sedation for the patient and without using an upper arm tourniquet.
The big advantage being?
The major benefit is functional. Because the patient is awake and comfortable, and there's no tourniquet paralyzing the muscles, you can ask them to actively move the structures you've just repaired during the surgery.
Like watching a flexor tendon glide after repair.
Exactly. You can directly visualize the tendon gliding smoothly through the pulleys, confirm there's no gapping at the repair site with active movement before you even close the skin. It's fantastic feedback. Plus, it cuts down on costs, avoids sedation risks, and can shorten hospital or recovery time. #If6. Complications and chronic nerve compression syndromes.
All right, let's shift gears and talk about what happens when things don't go perfectly, starting with complications. Non-union, a fracture failing to heal. Rare in the fingers, you said, but a big worry in the scaphoid.
Huge worry in the scaphoid. Up to 20% non-union rate, even if the fracture looked non-displaced on initial x-rays. That's why, again, clinical suspicion alone warrants immediate thumb spica splinting and that mandatory 2-week follow-up. If non-union does happen, treatment is complex. Aggressive surgical debridement of the non-union site, often bone grafting, and rigid internal fixation.
Stiffness. You called it the primary enemy. We know appropriate splinting prevents it, but if it does occur, what's the outlook?
Stiffness is indeed the primary enemy. It's caused by prolonged immobilization in the wrong position, really complex injuries with lots of soft tissue damage, or sometimes patient noncompliance with therapy. While we have surgeries to try and improve motion tenolysis to free up scarred tendons, capsulotomies to release tight joint capsules, the results are often disappointing. They rarely restore a completely normal range of motion. Prevention, by strictly adhering to that intrinsic plus position, MPs 90, IP 0, whenever possible during immobilization, is truly the best cure.
Any cut nerve carries the risk of forming a painful neuroma.
Right. A neuroma is basically a disorganized tangle of scar tissue and sprouting nerve axons at the site of injury, or where a nerve was cut. They can be exquisitely painful. The superficial radial nerve, SRN, on the back of the wrist thumb area is notorious for forming painful neuromas after injury or even surgery nearby.
How do you prevent or treat them?
Prevention involves meticulous nerve repair whenever possible. If a nerve has to be sacrificed or isn't repairable, the best strategy is often to resect the nerve stump back quite far proximally within the wound and bury the end deep within healthy muscle, or even drill a small hole in bone to tuck it into, keeping it away from the incision scar and areas prone to bumping. Treatment for existing neuromas can involve desensitization therapy, steroid injections, or ultimately surgical resection and burying the end.
Lastly, among major complications, complex regional pain syndrome, CRPS, formerly known as RSD. This is that Baffin condition where pain seems way out of proportion to the initial injury.
Exactly. Pain often spreading beyond the territory of the original injury, and it's associated with other strange symptoms. Changes in skin color, red, purple, pale, temperature differences, significant swelling, edema, abnormal sweating, and even changes in hair or nail growth in the affected limb.
There are two types.
CRPS type I occurs when there's no definitively documented major nerve injury associated with the inciting event. Type 2 occurs when there is the known nerve injury. But honestly, there's no single definitive diagnostic test for either. It remains a clinical diagnosis based on that constellation of symptoms and signs.
And the approach to treatment.
The key is early recognition and aggressive, multidisciplinary treatment. This includes specialized hand therapy focusing on desensitization and mobilization, medications like NSAIDs, sometimes gabapentin or antidepressants for nerve pain, and often sympathetic nerve blocks like stellate ganglion blocks. The consensus is that it's far safer to overtreat suspected early CRPS aggressively than to wait and let it become entrenched and potentially irreversible.
Okay, shifting from acute complications to chronic problems, let's discuss nerve compression syndromes. What's the basic mechanism, the pathophysiology?
It usually starts with some kind of chronic mechanical disturbance pressure, stretching, friction on the nerve at a specific anatomical pinch point. Early on, this mainly affects the nerve's myelin sheath, slowing down the speed of electrical conduction along the nerve. That's what nerve conduction studies pick up: early slowed velocity.
And if the compression continues?
If it's prolonged and severe enough, it starts to damage the axons themselves, the actual nerve fibers. This leads to axon death, which shows up on nerve conduction studies as a decrease in the amplitude, the strength of the electrical signal.
Symptoms follow the nerve's distribution.
Exactly. The classic triad is numbness, paresthesias that pins and needles feeling, and often pain, specifically in the anatomical area supplied by that compressed nerve.
The most common one by far is carpal tunnel syndrome, CTS, median nerve getting squeezed in the carpal tunnel at the wrist, containing those 10 structures.
Right. Diagnosis starts with the patient's story. Classically, waking up at night with numb, tingling hands, needing to shake them out. Dropping objects, difficulty with fine motor tasks like buttoning shirts or picking up coins. Thenar muscle wasting, that thinning of the thumb-base muscles, is a relatively late sign of severe chronic compression.
What about physical exam tests, Tinels, Phelan's?
Tinel sign, tapping over the nerve to elicit tingling, is somewhat helpful but not very specific. Phelan's test, holding the wrists fully flexed, is a bit better. But our sources suggest that the pressure provocative test, applying direct, firm pressure over the carpal tunnel for 30-60 seconds while the wrist is flexed, actually has the highest sensitivity for reproducing the symptoms in patients who truly have CTS.
How do we treat CTS?
Conservative management is always the first step. Night splinting, wearing a brace that keeps the wrist in neutral or slight extension, around 20 degrees, while sleeping, is often very effective, sometimes providing relief for years. A corticosteroid injection directly into the carpal tunnel can also be very helpful, both diagnostically, if it relieves symptoms, it confirms the location, and therapeutically, reducing inflammation.
Then if those fail?
Then surgery, carpal tunnel release is indicated. This involves cutting the transverse carpal ligament, the roof of the tunnel, to give the median nerve more space. This can be done through a traditional open incision in the palm, which is time-tested and very reliable long-term,
Or endoscopically.
or endoscopically, using small incisions and a camera. The advantages of endoscopic release are generally less immediate postoperative pain and potentially a slightly faster return to work. However, the long-term results, after about 3 months, seem to be equivalent between open and endoscopic techniques. The key caveat is that endoscopic release does carry a slightly higher, though still small, risk of complications like nerve injury, especially in the hands of less experienced surgeons.
Okay, the second most common nerve compression is cubital tunnel syndrome. Ulnar nerve getting squeezed at the elbow in that groove behind the medial epicondyle, the funny bone.
Correct. The nerve can get irritated by prolonged elbow flexion, direct pressure, or sometimes it can actually become unstable and snap back and forth over the bone. Symptoms are numbness and tingling, sometimes pain in the small finger and the ulnar half of the ring finger. Weakness comes later, manifesting as decreased grip strength, clumsiness, and difficulty fully straightening the ring and small finger IP joints due to intrinsic muscle weakness.
Physical exam findings.
You might see visible wasting or atrophy of the hypothenar muscles on the small finger side of the palm or in the spaces between the metacarpals where the interosseous muscles live. There are also specific signs to look for.
Like Wartenberg's and Frohman's.
Exactly. Wartenberg sign is when the small finger tends to sit away from the ring finger in abduction because the ulnar innervated adducting muscles are weak, leaving the radial innervated extensors relatively unopposed. Frohman's sign is a test of the adductor pollicis muscle, which is ulnar innervated and key for strong pinch. You ask the patient to pinch a piece of paper firmly between their thumb and index finger. If the adductor is weak, they will compensate by strongly flexing the IP joint of their thumb using their median innervated FPL muscle to hold onto the paper. That thumb flexion is the positive Frohman's sign.
Treatment starts conservatively again.
Yes, avoiding prolonged or repetitive maximal elbow flexion, maybe using elbow pads or night splints to keep the elbows straighter during sleep. If that fails, surgery might be needed. Options include simply releasing the tight tissue over the nerve in situ, just cutting the ligament without moving the nerve, or doing an anterior transposition where the nerve is actually moved out of the groove to the front of the elbow.
Is transposition better?
It used to be thought necessary for more severe cases, but more recent studies, as highlighted in our sources, suggest that simple in situ release often provides equivalent long-term results, even in advanced cases, and it's a less invasive surgery with potentially fewer complications. So many surgeons now prefer the simpler release when possible. Hashtag JackNeck7, degenerative joint disease and rheumatoid arthritis.
Okay, let's move into degenerative conditions, starting with common osteoarthritis or degenerative joint disease, DJD. Typically starts showing up after age 50. Symptoms are pain, stiffness.
Right, often worse with activity, sometimes exacerbated by weather changes. On X-ray, the classic signs are narrowing of the joint space, formation of bone spurs, osteophytes, maybe some increased bone density, sclerosis under the cartilage, and sometimes loose bodies within the joint. But here's a really important clinical point. The severity of X-ray findings does not always correlate well with the patient's symptoms. You might see terrible arthritis on X-ray in someone with minimal pain, or mild X-ray changes in someone with severe pain. So you always treat the patient and their functional impairment, not just the X-ray image.
Initial treatment is conservative.
Always. The triad is usually rest or activity modification, splinting, especially at night, and non-steroidal anti-inflammatory drugs, NSAIDs, keeping potential side effects like stomach upset or kidney issues in mind. Corticosteroid injections into the affected joint can also provide significant, though often temporary, relief. They can be tricky in the small finger joints due to the small space.
When conservative measures fail for the small joints like the MP or IP joints in the fingers, what are the surgical options?
Two main options. Arthrodesis, which means fusing the joint solid. This provides excellent, reliable pain relief and stability, but obviously at the cost of completely losing motion at that joint.
Or arthroplasty, joint replacement.
Yes. For finger joints, this usually involves either removing the joint surfaces and inserting a flexible silicone implant spacer, or using more modern resurfacing implants made of metal or pyrocarbon. Arthroplasty aims to preserve motion, but it rarely restores completely normal range, might not be as durable as fusion, and carries risks like implant loosening or breakage over time. Fusion is often preferred for the DIP joint, where motion isn't as critical, or for joints needing high stability or strength.
The thumb carpometacarpal, CMC joint, the basilar joint at the base of the thumb, is a really common site for painful DJD. That impacts grip and pinch.
Hugely. It causes pain with activities like opening jars, turning keys, strong pinching. Conservative management here relies heavily on splinting, often using prefabricated thumb spica splints that support the joint. Steroid injections can also be very effective here.
Surgical options for the thumb CMC.
The most common surgery is probably trapeziectomy, simply removing the trapezium bone, one of the small carpal bones involved in the arthritic joint. This reliably relieves pain. Whether you need to add some kind of ligament reconstruction or tendon interposition to stabilize the thumb base after removing the trapezium is debated, long-term results seem pretty good either way. The alternative for thumb CMC arthritis, especially in younger, high-demand patients like heavy laborers, is arthrodesis, fusing the thumb metacarpal to the trapezium. This provides excellent pain relief and outstanding durability, but the trade-off is some loss of motion, specifically making it hard to lay the hand perfectly flat on a table. Wrist arthritis, DJD in the wrist, is often secondary, right? Resulting from an old injury. Very often, yes.
Yeah.
Particularly from a missed or untreated ligament injury, like a tear of the scapholunate ligament. Over years, this leads to abnormal wrist mechanics and a predictable pattern of cartilage wear called scapholunate advanced collapse, or SLAC wrist. Other causes include old fractures or inflammatory arthritis.
If the arthritis is mainly confined to the radiocarpal joint, between the radius and the proximal carpal row, there are motion-sparing surgical options.
Yes, two main ones. The first is proximal row carpectomy, PRC. Here, the entire proximal row of carpal bones, scaphoid lunate triquetrum, is surgically removed. The discal row, primarily decapitate, then sits down and articulates directly with the radius bone. This procedure typically retains about 60–70% of the wrist's original flexion-extension motion and gives good pain relief. The second option is a limited wrist fusion, often called a four-bone fusion. In this case, the scaphoid bone is removed, and then the remaining lunate, capitate, hamate, and triquetrum are all fused together into one solid block. This block then moves as a unit on the radius. This procedure is generally considered more durable and perhaps better for younger, heavier-use patients, though it might sacrifice a bit more motion compared to PRC.
And if the arthritis is widespread, affecting multiple parts of the wrist, or if those motion-sparing options fail,
then the final, definitive salvage option is a total wrist fusion. This involves surgically fusing the distal radius bone directly to the third metacarpal, the middle finger metacarpal, essentially eliminating all wrist motion.
that sounds drastic, losing all wrist motion.
It is drastic, but it provides excellent pain relief and great durability. And functionally, patients tolerate it surprisingly well for most daily activities. The main limitations are things that require wrist deviation, like pouring from a pitcher or sometimes personal hygiene tasks.
Okay, lastly in this section, rheumatoid arthritis, RA, affecting the hand. This is different from DJD because it's an inflammatory process.
Exactly. RA is a systemic autoimmune disease where the body attacks its own joint lining, the synovium. Chronic inflammation of the synovium, synovitis, leads to cartilage destruction, joint swelling, and stretching or rupture of ligaments and tendons.
And it causes characteristic deformities in the hand.
Yes. Classically, the inflammation weakens the supporting structures, particularly on the radial side of the MP joints. This leads to the ligaments stretching out, allowing the joints to subluxate or slide forward volarly, and the fingers drift sideways towards the ulnar side. That combination, volar MP subluxation and ulnar deviation of the fingers, is a hallmark RA deformity.
RA often affects the distal radial lunate joint, DRUJ, too, the joint between the radius and ulna at the wrist.
Very commonly. Synovitis here weakens the supporting ligaments, allowing the head of the ulna to become prominent on the back of the wrist, a condition called caput ulnae.
And the danger of that prominent ulna head.
It acts like a sharp edge, rubbing against the extensor tendons that pass right over it on the back of the wrist. Over time, this can cause the tendons to fray and eventually rupture, one by one. It typically starts with the ECU tendon on the ulnar side and progresses radially, knocking out the small finger extensor, then the ring, middle, and so on.
So surgery for RA hand problems is complex.
Very complex. It has to address multiple issues simultaneously. The underlying synovitis needs to be removed, synovectomy. The joint instability or destruction needs correction, often with joint replacements or fusions. And any ruptured tendons need reconstruction, usually with tendon transfers or grafts, because the original tendon ends are often too frayed and diseased for primary repair. Treating the DRUJ problem might involve resecting the ulna head or performing a fusion procedure, Postoperatively, strict adherence to hand therapy is crucial, and prolonged splinting, especially night splinting, is often required because the underlying chronic inflammatory nature of RA means deformities have a tendency to recur.
Let's transition to some more specialized pathologies, starting with Dupuytren's contracture. This condition, first really detailed by Baron Dupuytren in the 1830s, involves the palmar fascia, the connective tissue under the skin of the palm.
That's right. For reasons not fully understood, but with a strong genetic link, especially to Northern European ancestry, the normal collagen bundles in the palmar fascia start to proliferate and change. Specialized cells called myofibroblasts become active, forming nodules, little lumps in the palm initially. Over time, these can coalesce and contract, forming thick cords that pull the fingers down towards the palm.
Non-operative treatments work.
Not really for the cords themselves. Corticosteroid injections might help with painful nodules early on, and splinting doesn't prevent progression. Once a cord forms and starts causing a contracture, you need intervention.
Options include minimally invasive procedures.
Yes. One is needle eponeurotomy or fasciotomy, where a needle is used to perforate and weaken the cord, allowing the finger to be straightened. It has a quick recovery but may be a higher recurrence rate. The other is enzymatic fasciotomy, using an injectable enzyme, Clostridial collagenase histolyticum, CFLEX, which digests the collagen in the cord. This is FDA approved, effective, but quite expensive.
And traditional surgery, open fasciotomy or fasciectomy, when is that indicated?
Surgery is generally indicated when the contracture becomes functionally significant. Common thresholds are an MP joint contracture of 30 degrees or more, or any PIP joint contracture. Often 20 degrees or more is used as a guideline, as PIP contractures are harder to correct. The open technique involves making incisions in the palm, carefully raising skin flaps. You have to be meticulous here to preserve the blood supply to the skin of the subdermal plexus, identifying and protecting the digital nerves and arteries, which are often encased or displaced by the cords, and then surgically removing the diseased cord tissue, fasciectomy.
It sounds straightforward, but our sources mention a high complication rate.
It can be surprisingly high, up to maybe 24% in some series. Potential complications include digital nerve injury, skin flap necrosis, hematoma formation, infection, and recurrence of the contracture. Post-operatively, patients need significant therapy and diligent extension splinting, often for 4 to 6 weeks, followed by night splinting for several months to try and prevent recurrence.
Okay, let's talk infections, often surgical emergencies in the hand. What are the common culprits?
Staphylococcus and Streptococcus species account for probably 90% of typical hand infections. However, you have to think about other bugs in specific situations. Human bites are notorious for Eikenella corrodens and other oral flora, often leading to polymicrobial infections. Intravenous drug users or diabetics might have more unusual or multiple organisms.
Infectious flexor tenosynovitis, FTS, infection inside the flexor tendon sheath. You said this is a true surgical emergency.
Absolutely. It's usually caused by a penetrating injury, like a puncture wound, that introduces bacteria directly into the sheath. The infection then spreads rapidly along the tendon within that closed space. The diagnosis relies heavily on recognizing Canavel's cardinal signs. You really need to know these.
Let's list them.
1. The fingers held in a slightly flexed posture. 2. There's fusiform, or sausage-like, swelling of the entire digit. 3. There's significant tenderness along the course of the flexor tendon sheath. And 4. There's excruciating pain with passive extension of the finger. If a patient has 3 or 4 of those signs, you have to assume FTS until proven otherwise.
And treatment is immediate.
Immediate. Start empiric intravenous antibiotics that cover staph and strep right away. If the patient doesn't show significant clinical improvement within about 12 to 24 hours of 5E antibiotics, then surgical drainage is mandatory. The surgical approach depends on the severity, often described by Michel's stages. Stage I might just have thin, serious fluid, possibly managed with catheter irrigation. Stage 2 has frank pus requiring open drainage. Stage 3 involves tendon necrosis, potentially needing extensive debridement or even amputation. Some surgeons use continuous irrigation systems post-operatively for a few days.
Okay, a felon. That's an abscess in the fingertip pulp.
Yes, a subcutaneous abscess in the distal pulp of the finger. Because the pulp has numerous vertical fibrous septa dividing it into small compartments, the infection creates intense pressure and throbbing pain relatively quickly. Drainage requires an incision, often a longitudinal one, directly over the point of maximal fluctuance, being careful not to cross the DIP joint crease or injure the underlying bone or tendon sheath.
And the collar button abscess. Sounds intriguing.
It describes an infection that starts deep in the web space of the hand, often in the subfacial space on the palmar side, maybe from a callus or blister. The infection then tracks dorsally around the metacarpal heads because the dorsal tissues are looser.
So the presentation is?
The patient presents with tenderness in the palm, but often much more impressive swelling on the dorsum of the hand over the web space. The fingers are often held spread apart in abduction. This type of abscess requires drainage through both volar and dorsal incisions to adequately clear the infection from both compartments.
The key diagnostic rule for any hand infection seems to be the clinical exam.
Absolutely. Carefully determining the area of greatest tenderness, fluctuance, and inflammation is still the most useful tool we have for localizing pus that needs surgical drainage.
Finally, in this section, compartment syndrome. We know muscles are grouped into compartments by tight fascia, if swelling occurs inside.
The pressure rises rapidly, compromising blood flow to the muscles and nerves within that compartment. This can happen in the forearm, which has 3 main compartments, volar, dorsal, and mobile wad, or in the hand itself, which has the nodar, hypothenar, adductor pollices, and 7 interosseous compartments.
Diagnosis relies on the classic signs.
Yes, the P's, although not all are reliable. Pain, especially pain out of proportion to the injury, is often the earliest and most important symptom. Palpation reveals tense, swollen, tender compartments. Paresthesias, numbness, tingling, indicate nerve ischemia. Paralysis is a late sign. Pain with passive stretch of the muscles within the suspected compartment is a very sensitive and crucial sign. For example, passively extending the fingers causes severe pain in the forearm if the volar flexor compartment is tight.
Pulselessness.
Pulselessness is a very late and ominous finding, indicating arterial compromise, and you absolutely don't want to wait for that. The diagnosis should be made clinically long before pulses are lost.
What causes it?
Intrinsic causes are things like bleeding or swelling from a fracture within the compartment. Extrinsic causes are things like overly tight casts or dressings, or sometimes infiltration of IV fluids, especially hyperosmolar ones.
Can you measure the pressure?
Yes, using specialized devices with a needle or catheter inserted into the compartment. Generally accepted thresholds for surgical intervention, fasciotomy, are absolute compartment pressures above 30 to 45 millimeters of mercury, or pressures that come within about 20-30 millimeter Hg of the patient's diastolic blood pressure.
And surgical management is urgent fasciotomy.
Emergent fasciotomy. All involved compartments must be released. For the forearm, this usually involves long incisions along the mid-radial and mid-ulnar aspects, making sure to release the volar, dorsal, and mobile wand compartments, often including release of the carpal tunnel as well. For the hand compartments, incisions are typically made dorsally over the index and ring metacarpal shafts to access the interosseous compartments, plus releases for the hypothenar if needed. Critically, these fasciotomy incisions are left open initially, covered with sterile dressings. The patient needs to return to the operating room every 2-3 days for re-exploration, washing out the wounds and assessing muscle viability, debriding any dead tissue, until the swelling subsides and the wounds can be closed, often with skin grafts. Delaying fasciotomy risks permanent muscle death and nerve damage, leading to a devastating Volkmann's ischemic contracture.
All right, shifting focus now to tumors of the hand and wrist. When a patient presents with a lump or mass, what's the disciplined diagnostic approach?
First steps are always a careful history and physical examination, followed by plain X-rays. X-rays are great for assessing any underlying bone involvement or calcifications within the mass. Depending on those findings, advanced imaging might be needed. CT is best for evaluating bone destruction or extension. MRI is superior for defining the soft tissue extent of the tumor, its relationship to nerves and vessels, and any intramedullary bone lesions. Bone scans, scintigraphy, can sometimes help assess vascularity or metabolic activity.
When is a biopsy warranted? Not every lump needs one, right?
Correct. But there are definite indications. Any mass larger than about 5 centimeters, any mass that is rapidly growing, causing significant pain, or have an aggressive appearance on imaging, like bone destruction, absolutely warrants a biopsy to rule out malignancy.
And the biopsy is always the last step.
Always the last step, done only after all the clinical and imaging information has been gathered and a potential treatment plan is considered. The type of biopsy depends on the suspicion and size. Small, likely benign lesions might have an excisional biopsy, removing the whole thing. Larger or potentially malignant lesions require an incisional biopsy, taking just a piece. If malignancy is suspected, the biopsy must follow strict oncologic principles. Usually a longitudinal incision placed directly over the tumor, taking the most direct path possible, avoiding contamination of uninvolved tissue planes or critical structures. Ideally, the biopsy should be performed by the surgeon who would do the definitive resection, or at least planned in coordination with them, so the biopsy tract can be removed along with the tumor later if it proves malignant.
Okay, let's talk about the most common types. Benign soft tissue tumors are the most frequent. The number one is.
The ganglion cyst accounts for maybe 50 to 70% of all soft tissue masses in the hand and wrist, most commonly found on the dorsal aspect of the wrist, typically arising from a stalk connected to the scaphoidal ligament area. They are filled with thick, clear, jelly-like fluid, mucin, and characteristically transilluminate. They light up when you shine a pen light through them.
What causes them?
The exact cause isn't perfectly clear, but the leading theory involves repeated minor stress or degeneration in the joint capsule or ligament, leading to increased production of hyaluronic acid and other mucopolysaccharides, which then leak out and form the cyst.
Treatment options?
Aspiration, draining the fluid with a needle, is simple, but has a very high recurrence rate, somewhere between 15 and maybe even close to 90% because the stalk remains. Surgical excision, removing the cyst along with its stalk down to the joint capsule or ligament origin, has a much lower recurrence rate, but it's obviously a more involved procedure with surgical risks. Many resolve spontaneously, too.
The second most common benign soft tissue tumor.
That would be the giant cell tumor of the tendon sheath, or GCTTS, also called pigmented villonodular synovitis, PVNS, of the tendon sheath. These are typically slow-growing, firm, often multilobulated masses, usually found on the fingers, often near the PIP joints. They arise from the synovial lining of the tendon sheath.
They have a characteristic appearance.
Yes, pathologically they contain hemosiderin-laden macrophages, which gives them a distinct deep brown or yellowish color on cut section. Treatment is marginal excision, just shelling the tumor out. However, they have a surprisingly high local recurrence rate, maybe 4 to 44%, so careful follow-up is needed.
What about tumors arising from nerves?
The most common benign peripheral nerve sheath tumor is the schwannoma. This is an important one to recognize. It's typically well encapsulated, arises from Schwann cells on the surface of the nerve sheath, and critically, it usually displaces the actual nerve fascicles rather than invading them. This means it can often be carefully dissected away from the nerve fibers, preserving nerve function. MRI is essential preoperatively to assess the relationship to the nerve. This contrasts with a neurofibroma, which tends to grow within and among the nerve fascicles, making resection without sacrificing the nerve very difficult or impossible.
Okay, moving to malignant tumors. What's the most common primary malignancy of the hand itself?
That would be squamous cell carcinoma, SCC, of the skin. Accounts for probably 75 to 90% of primary hand malignancies. It's also the most common malignancy found in the nail bed region.
Risk factors.
Chronic sun exposure is a major one, especially on the dorsal skin. Also radiation exposure, chronic non-healing wounds or burn scars, where it's called a Margolin's ulcer, and immunosuppression. Treatment is wide surgical excision with clear margins, typically 0.5 to 1.6 centimeter.
Melanoma can occur on the hand too.
Yes. Prognosis is directly related to the Breslow thickness, how deep the melanoma invades. For melanomas thicker than 1 millimeter, a sentinel lymph node biopsy is usually recommended to check for microscopic spread. Subungual melanoma under the nail typically requires amputation at the DIP joint level for adequate margins.
What about sarcomas, malignant tumors of connective tissue, not skin?
Non-cutaneous sarcomas are rare in the hand, thankfully. When they do occur, epithelioid sarcoma is actually the most common primary soft tissue sarcoma of the upper extremity, often presenting as firm nodules in young adults. These are highly aggressive. Treatment for most high-grade sarcomas in the hand or forearm often requires radical resection, meaning removal of the entire involved muscle compartment, frequently necessitating amputation proximal to the tumor to achieve clean margins. Because the treatment is so drastic, biopsy and definitive management should absolutely take place at a specialized sarcoma center.
Lastly, let's touch on a few key benign bone tumors seen in the hand.
Okay, first the enchondroma. This is the most common primary bone tumor found in the small bones of the hand, the phalanges and metacarpals. It's a benign tumor of cartilage origin, usually discovered incidentally on X-ray as a lucent lesion inside the bone, sometimes presenting with a pathologic fracture through the weakened bone. While benign when solitary, multiple enchondromas occur in syndromes like Ollier's disease or Maffucci syndrome, which carry an increased risk of malignant transformation to chondrosarcoma later in life. Second, osteoid osteoma, a small, benign, bone-forming tumor. The hallmark symptom is pain, typically worse at night, and characteristically relieved dramatically by NSAIDs like aspirin or ibuprofen. Third, giant cell tumor of bone. This one is technically classified as low-grade malignancy or locally aggressive benign tumor. It has metastatic potential, usually to the lungs, and a high local recurrence rate after simple curettage. Treatment requires aggressive resection, often involving curettage plus adjuvant treatment like phenol or cryotherapy, and packing the defect with bone graft or cement.
Our final section tackles some really complex reconstructive challenges, starting with burns to the hand. These are always considered severe injuries, right?
Always severe, often requiring transfer to a specialized burn center. Burns are classified by depth. Superficial, like sunburn. Superficial partial thickness. Blisters, painful, usually heal well. Deep partial thickness. Mottled appearance, decreased sensation, often need grafting. And full thickness, or third degree, insensate leathery appearance, always require grafting.
Acute management focuses on
Circulation is paramount, especially with circumferential burns around a finger or the whole hand. The tightening burned skin, Escher, can act like a tourniquet. Esterotomy, making surgical incisions through the full thickness of the Escher, may be needed urgently to relieve pressure and restore blood flow. These incisions are typically made along the midaxial lines of the digits sides, avoiding the palmar and dorsal surfaces used for grasp and contact.
And splinting is critical from day one.
Absolutely critical to prevent devastating contractures. The hand must be splinted immediately in that intrinsic plus position. MPs flexed around 70 to 90 degrees, IPs fully straight, 0 degrees, thumb abducted, and wrist in about 15-30 degrees of extension. Maintaining this position is vital during the acute healing phase.
Surgical grafting is needed for deeper burns.
Yes, deep partial thickness and full thickness burns require skin grafting once a suitable wound bed is achieved. On the dorsal hand, unmeshed sheet grafts are preferred for better cosmetic appearance. On the palmar surface, thicker, full-thickness grafts are sometimes used for better durability and less contraction.
What if the burn exposes deeper structures like bone or tendon?
Standard skin grafts won't take directly on bare bone or tendon lacking blood supply, peritoneum. In these cases, more complex coverage is needed. This might involve local or distant flaps, transferring skin and soft tissue with its own blood supply, or the use of a cellular dermal substitutes like Integra.
How does Integra work?
Integra is a two-layer product. A temporary silicone outer layer acts like epidermis, while the inner layer is a matrix of collagen and glycosaminoglycan that acts as a scaffold for the body's own cells to grow into, essentially regenerating a layer of dermis over 2-3 weeks. Once this dermal layer is vascularized, the silicone sheet is removed, and a very thin split-thickness skin graft is placed on top. It's a powerful tool for reconstructing deep burns over critical structures.
Long-term, the most common deformity after hand burns is
Web space contractures, where the skin between the fingers tightens and limits finger spread. These are typically reconstructed later using techniques like Z-plasty or other local flap rearrangements to release the contracture and deepen the web space.
Okay, briefly touching on vascular diseases, Hypothenar-Hammer syndrome.
This is an occlusion or aneurysm of the ulnar artery in the palm, specifically where it passes over the hook of the hamate bone. It's caused by repetitive trauma or vibration to the heel of the hand, like using the hand as a hammer. Treatment usually involves resecting the damaged segment of the artery. Whether it needs reconstruction with a vein graft is debated.
And viscospastic disorders, Raynaud's.
This involves episodes of exaggerated vasoconstriction in the fingers, and sometimes toes, triggered by cold or stress, causing them to turn white, then blue, then red as blood flow returns. We distinguish Raynaud's disease, which is usually milder, occurs in young women, is bilateral, and has structurally normal arteries, from Raynaud's phenomenon, which is often associated with an underlying connective tissue disease like scleroderma, can be more severe and may involve actual structural narrowing stenosis of the digital arteries. Treatment involves avoiding cold, smoking cessation, sometimes calcium channel blockers. In severe cases, surgical options include digital sympathectomy, stripping the adventitia, the outer layer containing sympathetic nerves, from the digital arteries, or injections of botulinum toxin around the vessels, which can sometimes improve blood flow.
Finally, congenital differences, often called congenital anomalies. The Swanson classification is used.
Yes, it categorizes them based on the developmental failure of formation, separation, duplication, etc. Syndactyly, or webbed fingers, is the most common, resulting from failure of the programmed cell death that normally separates the digits in utero. Surgical correction involves carefully separating the digits using zigzag incisions, local flaps, and often requires full-thickness skin grafts harvested from the groin or abdomen to cover the created defects between the fingers. Polydactyly, or extra digits, is also common. Duplication of the thumb is classified by Wassel based on the level of duplication. Reconstruction is complex and often involves merging elements from both duplicated thumbs to create the best possible single functional thumb, rather than just simply amputating the smaller one.
And this brings us to the absolute cutting edge. Reconstructive transplantation, like hand transplants. Technically feasible now.
Yes, technically, hand transplantation has been successfully performed since the late 1990s. Harvest techniques have improved compared to acute replantation after traumatic amputation, allowing better preservation.
But the major hurdle remains the trade-off.
It's a profound ethical and medical trade-off. Unlike transplanting a vital organ like a heart or liver, where the alternative is death, limb absence is not immediately life-threatening. Therefore, committing a patient to lifelong immunosuppression with powerful drugs like tacrolimus, FK506, carries significant long-term risks, increased risk of infections, certain cancers, kidney damage, nephrotoxicity, metabolic problems. These risks must be weighed very carefully against the potential functional and psychological benefits of receiving a hand transplant.
So research is focused on reducing that need for immunosuppression.
Intensely. Much research is exploring ways to induce immunologic tolerance, often using protocols involving transplantation of the donor's bone marrow along with the hand, hoping to create a state of chimerism where the recipient's immune system accepts the donor limb without needing such high levels of chronic immunosuppression.
Candidate selection must be incredibly strict.
Extremely rigorous. It requires extensive screening covering medical factors,
Yeah.
immunologic compatibility, nerve vessel anatomy suitable for connection, but also critical psychological and social factors. The patient must have demonstrated excellent compliance with medical care in the past, have strong social support, and possess the psychological fortitude to cope with the challenges of rehabilitation and living with a visible limb from another person.
It really brings us back full circle to the complexity and the high stakes involved in this field. Hashtag XEC outer.
It does. We started by saying the hand's complexity demands this elite integrated approach. And we've covered a huge amount from the tiny mechanics of the TFCC load sharing right up to the really heavy ethics of transplantation. I think the final key takeaway, the message that runs through all our source material is this. Healing the specific injury, the bone, the tendon, whatever it is, that's not the end point. The real goal of any intervention in the hand must be to achieve healing, yes, but also relief of pain and absolutely critically, the maximization of overall function for that patient.
Function is king.
Always.
And for you, the listener, maybe take away that one specific anatomical detail that protects function. The intrinsic plus position. MP joints at 90, IP joints at 0. Knowing and applying that seemingly small detail can be the difference between a good outcome and a lifelong disability from stiffness. It really encapsulates the kind of specific, crucial knowledge needed in this elite field. So what vital anatomical detail will you use to inform your understanding, maybe impress your colleagues tomorrow?